Again, I appreciate you all for coming and spend some time with us talking about diabetes. You don't have to answer, but just for a show of hands, if you want to answer, who in here has type 2 diabetes? Who in here has type 2 diabetes? Okay. And who here knows someone close to them that has diabetes that you're here to learn more about? Good. So a little bit of a mix of both. So just to give a brief overview of tonight's talk, although it's of course, formal talk with a slide set, I want to make this more interactive, and if you have any questions that come up, feel free to stop me and ask me those questions. We'll try to have some questions at the end as well. So first I'm going to go over what diabetes is. We're going to go over some of the diagnostic criteria that we use to diagnose diabetes. We're going to briefly touch on some of the common risk factors for diabetes. That will, of course, lead into a discussion on the obesity and diabetes trends in the United States over the past 20 or 30 years. I'll touch on some of the diabetes-related complications, some of the management goals, and then if we have time, we'll talk about some of the available treatments. And of course, as I mentioned, we will have time for questions and answers at the end, but if any questions come up during the talk, please feel free to interrupt. So diabetes, blood sugar, also called glucose, is the main nutrient that every cell in the body uses for fuel. The important concept, though, is that insulin is required for the cells to take sugar out of the blood. So if there is either not enough insulin or the insulin that the body makes is not effective to tell the cells to take the sugar out of the blood, glucose stays in the blood and the blood sugar rises. And when it rises to a certain point, that becomes diabetes. Historically, the most common way that we diagnose diabetes is through a fasting plasma glucose. This is a basic fasting blood test that most of us probably have had. If that test is under 100, that's considered normal. If that test comes back more than 126 on more than 2 separate occasions, that meets the criteria for diabetes. There's a big category here in patients who aren't quite normal, but yet don't meet the criteria for diabetes. We have a name for that, and that's prediabetes. We'll talk about that in just a moment. Another way that we can diagnose is with what's called an oral glucose tolerance test. This is where we give a fixed amount of sugar for a patient to drink, and we check a blood sugar 2 hours later to see their response to sugar. If that test comes back less than 140, that's considered normal. If that comes back more than 200, that meets the criteria for diabetes. And again, you have this in-between category that's considered prediabetes. In 2010, very recent, the ADA added the use of the A1C test as a way to diagnose diabetes as well. The A1C has been historically used. It's a very old test. It's used for patients with known diabetes as a way to monitor their blood sugars over time. A1C, for those patients who have diabetes, know that this is a reflection of average blood sugar for 2 or 3 months. So this test was added in 2010 for those patients who are either not able to do a fasting blood sugar or for other reasons that they just can't do it. So you can use an A1C, although the preference is to use a fasting blood sugar. The oral glucose tolerance test is used much more commonly in Europe. So there are 2 main types of diabetes. The first type is called type 1 diabetes. This is seen in about 5 or 10% of patients with diagnosed diabetes. This type of diabetes used to be called other things such as childhood onset or juvenile onset diabetes. Other terms used to be insulin-dependent diabetes. Those are terms we don't use anymore. The current term is type 1 diabetes. This form of diabetes, the body has essentially no insulin production. So you have no insulin. So by definition, you essentially need insulin from the very beginning of the diagnosis. It does often affect children first. They're diagnosed in young childhood. However, I've diagnosed patients in their 50s with type 1 diabetes. So really, age is not a criteria. Type 2 diabetes is the most common type and is the main focus of tonight's talk. That makes up the bulk of patients with diabetes, about 90% or more. This used to be called adult onset or non-insulin dependent diabetes. These terms, again, are not very appropriate because, unfortunately, with the obesity epidemic, I've diagnosed children, teenagers with type 2 diabetes, and many patients with type 2 diabetes ultimately do require insulin, so non-insulin dependent is not appropriate either as a term. So I mentioned a little bit about prediabetes. approximately 80 million Americans are thought to have prediabetes. That's the blood sugar that's above normal, but not high enough to meet criteria for diabetes. This is a big concern because this is what you would term as the iceberg underneath the tip. There is an increased risk of developing diabetes if you have prediabetes. It just makes sense that if your blood sugar is already elevated, you're more likely to have it go up even further in the future. Also, patients with prediabetes are at increased risk of cardiovascular disease. So it's important to identify people in this category because if we can identify them early enough, we can offer interventions that we know can help reduce the onset of diabetes. And we do know that patients with prediabetes can delay or even prevent the onset of type 2 diabetes with lifestyle intervention, and in some cases, we use medication. So the estimated cost of diabetes is large, although with the recent bank bailouts, these numbers don't seem so large anymore. But we spend about $175 billion on diabetes every year. The bulk of that, of course, is the medical cost to treat patients with diabetes. But we shouldn't forget that $58 billion is related to the disability and lost time of work that's seen in patients with diabetes. So risk factors. There are a lot of different risk factors. These are the most commonly accepted ones. Prediabetes, I just mentioned, patients with prediabetes are more likely to develop diabetes in their future. Patients over the age of 45. People that have a family history of diabetes and a parent or a sibling have a higher risk of developing diabetes themselves. Patients who are overweight, people who don't exercise on a regular basis. People have a low good cholesterol. HDL is also called good cholesterol. So having a low good cholesterol or high triglycerides or high blood pressure also increases your risk of developing diabetes. Certain racial and ethnic groups, African Americans, Hispanics, American Indians, these all have a higher rate. Women who have had gestational diabetes or who have had a baby weighing more than 9 pounds at birth. Gestational diabetes is diabetes that's seen in pregnancy. These women have a 50% likelihood of developing diabetes in her lifetime. So it should be noted. So this next bunch of slides depicts the epidemic that we all read and see in the newspapers and on television. Over the last 30 years, we have seen an explosion of the obesity epidemic in the United States. This map series will show you the proportion of the population who are obese based on a body mass index of more than 30. That's approximately 20% overweight. You see here by state. Keep an eye on the legend. I'm going to go back to 1986. Keep in mind that no state had more than a 14% obesity proportion in their population. And it is noteworthy that as I go year after year, we see here that 5 years later they had to add a new category of 15 to 19%. Let's keep going. We keep going 5 more years, we have to add another category, more than 20%. We add a couple more years. We see here that Mississippi is the first state to achieve more than 25%. They are closely followed behind with other states in the southeast. You see here. And this is not curtailing. This rate is continuing to go up. New Jersey, we look pretty good, don't we, relative to everyone else. But if you compare us to what we were before, I believe we were in the blue, less than 10%. We now doubled in the last 25 years. If you compare us to where we were in 1990 to where we were now in 2009, the biggest thing, couple things I take home from this, is that no state in 1990, just 20 years ago, had more than 14% obesity. Now, 20 years later, no state has less than 15% obesity. One might also take away from this that maybe we should just move to Colorado. Right. So closely following this obesity epidemic is the diabetes epidemic, because we know that obesity is a risk factor for type 2 diabetes. Well, you're going to see a very similar trend in 1994. You see here a different color scheme, except for South Carolina. Every state has less than a 6% rate of diabetes. Let's just keep going year after year after year after year until we get to 2009. It's pretty apparent that we are dealing with an epidemic. Now we see that most states are more than 6%. Obesity is 20% over your top of your weight range. So for a person who weighs 5'4" at 150 pounds, 180 pounds would be obese. So 30 pounds is a good number to keep in mind as being obese. And I use the term obesity. It's a term that many people don't like, but it's an appropriate term. It's just a definition based on a number. So it's an important term. Just like prediabetes, people don't like a name. They like it to be touch of or a little bit of. These are euphemisms, and I think it takes away from the danger that these things have. So this chart shows you by graph form that we see here in 1981, less than 6 million Americans had type 2 diabetes. Now we see here about 20 million have diagnosed diabetes. But what's really striking is the curve. Here's the slope of this curve here, but this has taken a huge run up, and this is not letting up. So in 2011, it's estimated that nearly 26 million adults have diabetes, most of them, of course, being type 2. 7 million people do not even know they have it. We know that about a third of patients don't know they have diabetes. They're undiagnosed. When a patient is diagnosed with diabetes, on average, they've had it for 8 years. So it's important to get screened, and we'll touch on that a little bit. 11% of the population, of the adult population, has diabetes. But when you look at only people over the age of 60, that goes up to more than 1 in 4. So age is a big predictor of type 2 diabetes. The reason why it's important, of course, to diagnose diabetes is that we can treat diabetes and we can prevent the complications that we see in patients with type 2 diabetes. The complications can be separated into two main categories. The first category is called microvascular, or small blood vessels. We see these in the eyes, in the kidneys, and the nerves, especially the nerves down to the feet. And this is separate from the large or macrovascular complications. And this is where we see large blood vessels leading up to the brain, blood vessels in the heart, and blood vessels going down to the legs. So there's two main categories of complications that we can either prevent or reduce by treating. A couple of statistics. It's important to note that 2 out of 3 patients with diabetes ultimately die from heart disease or stroke. So that is really the main focus, or at least should be the main focus when we manage diabetes, not just focusing on blood sugar, but focusing on the overall risk of heart disease and stroke. Diabetes is still the #1 cause of adult blindness and kidney failure. Fortunately, although this sounds like a lot, this doesn't happen often because of our techniques at controlling blood sugar. And diabetes causes more than 60% of lower extremity amputations that are not due to trauma. So preventing complications. Tight blood sugar control is very important at reducing the damage seen in the small blood vessels. As I mentioned, the eyes, the kidneys, and the nerves down to the feet. But no good study has shown that controlling blood sugar reduces the risk of heart disease and stroke, which is, as I mentioned, the biggest concern that we ultimately have. So that's where you end up focusing on blood pressure, which reduces the risk of both small blood vessel and large blood vessel complications. And cholesterol control should be very important in management of type 2 diabetes. Instituting good preventive care practices for eyes, kidneys, feet, teeth, and gums are also very important. So micro is a term called small, and macro is large. So micro are the very small blood vessels, we call them capillaries, in the back of the eye, in the kidneys, very, very small, and in the nerves. Whereas the large blood vessels are the carotid artery, the arteries going to your heart. They're larger blood vessels. So that's the difference between micro and macro. We know that patients with prediabetes, if 7%, which is a modest weight loss, is seen, you can reduce the risk of progressing to diabetes by 60%. If you look at just those patients over the age of 60, that reduction goes up to 70%. So we shouldn't underestimate the impact that a modest amount of weight loss can do. So again, treatment of diabetes lifestyle modification is really the first hallmark of the management, and really it should be instituted in patients across all spectrum of their disease. We know that good lifestyle change can decrease the need for medications. Many patients, especially when they're first diagnosed, they can manage their diabetes with good lifestyle control for many years. In patients who do lifestyle change, they can reduce the risk of other associated illnesses. We talked about heart disease, stroke, arthritis, other issues that can be seen with being overweight. And it improves the sense of well-being and overall quality of life, which really that's the most important thing. We can use a lot of treatments, but if people feel lousy, that's not good. So good lifestyle change would hopefully help people feel better. I encourage patients to strive to become more physically active. I would start off slowly. Of course, I would recommend anyone who has not generally been very active should, of course, consult with their doctor to see if any testing needs to be done first. But I recommend starting off slowly and reaching about 30 minutes a day for about 5 days per week of moderate intensity exercise. And I would start slowly. It can be as little as starting off with 5 minutes and increasing by a minute a day up until you reach 30 minutes. So you don't have to do it all at once right from the very beginning. And it doesn't have to be going to the gym. We can build a lot of physical activity into our daily life. Taking a lunch break and walking during work also helps with stress from work. Taking the stairs instead of the elevator when appropriate. And parking further away from the stores or your office building. And definitely keep at it. I recommend finding something that you enjoy. Because if you don't enjoy the activity that you're doing, it's not going to last. You need to enjoy it. And the longer you keep at it, the better you'll feel. And it will work. Certainly celebrate small successes as you reach a new milestone that you've set. And I would recommend setting short-term achievable goals. And when you achieve those goals, certainly celebrate that as you make a new goal for you for the next couple of weeks. This interesting picture I found online. Only in America do you see people taking the escalator up to their gym, which is open 24 hours a day. All right. So in addition to physical activity, of course, nutrition needs to be part of a good lifestyle intervention. I encourage anyone who is having concerns about their weight, meeting with a nutritionist or a diabetes educator who is also a nutritionist is important to have a tailored one-on-one program designed for you. We know that there's a lot of ethnic and racial and other restrictions that people have on their dietary intake that really need to be individualized. Carbohydrates make up 60% of what we consume in calories. Carbohydrates, or people talk, sugars is one type of carbohydrate. Whole grains, fruits, vegetables, these should all be included in a healthy diet. I stress the total amount of carbohydrates much more than I do the type of carbohydrate. There's a lot of stuff presented online and in textbooks and magazines, on internet and radio, that glycemic index is the catchphrase that people use, that we know that some carbohydrates cause blood sugar to go up different ways than other carbohydrates. In my experience, I would really stress the total amount of carbohydrates more than the particular type of carbohydrate. And this is important because if you can make one change, that would be a simple change, would be cutting back the portion of the carbohydrates you already consume, as opposed to trying to figure out how to replace it with something that's different glycemic index. Certainly, if you said, well, what about whole wheat pasta versus regular pasta? Well, whole wheat pasta, if I had the choice, would be a better option, but eating less pasta overall would be better than switching it to whole wheat pasta. Sugars are certainly acceptable, but certainly we'd want to replace that with, substitute with other carbohydrates. Having a cannoli after Italian meal is probably not the best idea, although it is good. Fiber is considered a carbohydrate. We just don't digest we don't digest fiber down to sugars, so it's not included as a sugar, but this is encouraged. Protein, there is no specific recommendation for a change in the amount of protein that's normally recommended for patients in general to be healthy. In terms of fat, less than about 10% of calories should come from the really bad saturated fat, and less than 300 milligrams of cholesterol should be consumed every day. Trans fats, we all have heard about trans fats and the significant health concerns that we see. So certainly minimizing the intake of trans fats is an important recommendation. I mentioned the food industry, they're very creative. They fought for many years on the concerns and risks of trans fats. They said it doesn't exist, there's no concerns, just like any other form of fat. But a lot of evidence is suggesting that trans fats actually change your underlying genetic, the way your genes respond to what you're eating and what you're doing. These trans fats actually change the way your genes respond. They don't change your genes, they just turn on certain genes which we believe can be detrimental to your metabolic health. So they fought for many years about this, saying, first they said it wasn't dangerous. Then they said, okay, maybe it's dangerous, but that's what the consumer wants because they taste better. They are, the chewy cookie as opposed to the hard cookie, it's because of trans fats. So finally they decided as a group, an industry, they're going to take the lead. So they've now been starting to advertise that we are removing the trans fat from our products. But they're creative because you go down the snack aisle, which I've done a couple of times recently, and you see these big packages. Of course, everything is family size now. They no longer have these little packages. And they have this big package with this huge banner, which has some shade of green, because green seems to be the color of health. And it says 0 grams of trans fats, as if all of a sudden that bag of Doritos is now healthy for you. So number of calories, that's how weight changes. Weight is a calorie balance. The amount of calories that go in must equal the amount of calories that go out. If it does not go out, it gets stored, and that's weight gain. 3,500 calories equals 1 pound. So if you are consuming, let's say, for example, the average diet is, let's say, 2,000 calories a day, and your weight is stable, then you know that you are burning, everything you do, you're burning 2,000 calories a day because your weight is stable. If you can change that by, let's say, cutting back 300 calories a day and burning, by exercising, 200 calories a day, you would have a net loss of 500 calories per day. Well, if 3,500 calories equals 1 pound, 500 calories a day, it would take a week to lose a pound. 4 pounds a month, 50 pounds a year. So you can see how small change can really add up. So certainly the number of calories you consume should be individualized to your weight that you need to change. Again, meeting with a nutritionist or a diabetes educator who is also a nutritionist can help. And it's not just the total number either. It's how you consume the calories. Many patients come back and they've been on a lower calorie diet and they haven't seen the weight loss that they would maybe expect. And when you sort of get more questioning, it turns out that they're skipping meals to get the calories down, or they're eating calories at the wrong time of the day, they're not eating the right types of calories. So it's a lot of factors that go into weight control. We know that exercise, behavior modification, and ongoing support are usually important and necessary for permanent long-term weight control. There's no clear evidence, scientific evidence, that any particular supplement, vitamin, mineral, herbal supplement, whatever it is out there, is beneficial for diabetes, unless, of course, there is a deficiency, in which case you should replace it. For most people that need a basic multivitamin preparation should be sufficient. Limiting alcohol is important for everybody. If someone has very high triglycerides, avoiding alcohol should be encouraged because alcohol can actually raise your triglycerides in the short term. And for patients with hypertension, high blood pressure, especially that's not controlled, limiting salt intake is also important. It's important to note also that many times if you limit things like salt or trans fats, you are probably reducing bad foods. So it's sort of a whole lifestyle change. So the management goals for diabetes, an easy way to remember it is the ABCs of diabetes. The A stands for the A1C. That's that test I was mentioning before. This is a test that helps us. It's a blood test, but it indicates an average blood sugar over approximately a 2 or 3 month period of time. It's usually reported as a percentage. 7% is the American Diabetes Association goal. Patients who can get to under 6.5% might be appropriate, but the main goal is under 7%. The interesting thing about this is, and patients can be diagnosed when they're 15%, just to give a relative range. So people generally are in the 7, 8, 9% range is mild to moderately uncontrolled. Above 9% is poorly controlled, and then above 11% is very poorly controlled. So for every 1% you lower your A1C from 10 to 9, 9 to 8, 8 to 7, you reduce your risk of the small blood vessel damage in the eyes, the kidney, and the nerves by 30 to 40%. For every percent you lower it, you reduce the risk of all those complications by 30 or 40%. Okay? So under 7% is the goal. Interesting, people thought, well, why don't I just get down to normal? Because 7% is not normal. Normal is 5%, 5.5%. That's normal. And the other question that came up is, I mentioned before that controlling blood sugar has never been shown to really reduce the risk of having a heart attack or a stroke. Right? So the US government put together a clinical trial, very large trial, called the ACCORD trial. And it looked at, well, maybe we're not seeing the reduction in heart disease because we're not targeting a normal A1C. We're targeting a goal A1C of 7%. So that's what the study looked at. And they had a group of people that they tried to get to under 6%, and the other group they tried to get under 7%. Well, the study was stopped early. Studies are usually never stopped early. The reason why it was stopped early is people that tried to get under 6%, more of them died. Right? More of them died. Well, there's a lot of research now because it just came out recently, and they're looking at why that was seen. But that was more of them died compared to achieving 7%. So it reminds us that the goal of 7%, which has been well established, should be the goal for the majority of patients with type 2 diabetes. Trying to drive that down even lower with a lot of medication generally has not been shown to be effective, and there may be some risk about doing that. All right. So people that have diabetes, the range for treatments, generally, everyone has a different pattern. But generally, if you start a meal at 90 to 130 and you go up to no more than 180 after a meal, your average blood sugar will be about 150 or less, which would equate to an average A1C of under 7%. So these are good general targets. That's the A. The B is for blood pressure. ACE inhibitor and ARB are two classes of high blood pressure medications that have been shown in numerous studies to reduce the risk of kidney damage from diabetes. So these medications are often used to control blood pressure. Cholesterol, I mentioned before, and it cannot be understated the importance of reducing the risk of cardiovascular disease and stroke. Cholesterol medications are vitally important in doing that. We cannot change many things about a patient. We can't change your age, although we try. We can't change your genetics. You can't change your parents. You can't change your gender. You can't change things that are inherently about you. But you can change the environment around you. Proper sleeping habits, proper exercise routine, proper eating habits, good stress control. Right? Those are 4 things to be healthy. But what you also can't change is you can change your risk factor for heart disease if you have diabetes, and that's by using a medication for cholesterol. Many studies have shown that, and it's very well established, that patients with diabetes have a 400% likelihood of having heart attack or stroke. So this is a real concern. Patients who have normal cholesterol numbers with diabetes still have a much higher rate of having a heart attack or a stroke, more than someone who does not have diabetes. Furthermore, patients with diabetes with a normal cholesterol panel, if you look at the numbers, it's all normal. If you give them what's called a statin, a particular type of medication, you reduce the risk of having a heart attack, stroke, and dying by 30 to 40%. So these medications, in my opinion, are part of the reason why, despite all the stats that say that obesity and diabetes is increasing in proportion, why we're still living longer than we did 30 years ago. Metformin is the most commonly prescribed medication for diabetes in the United States. It does have some mild stool issues that most people, it subsides after the first week or so. It can promote weight loss, although it is not a weight loss drug. And there is no risk of low blood sugar, meaning it lowers blood sugar to normal, but cannot lower it below normal in the absence of any other medication. The next group of, there's only 2 medications that are generic in the United States. The other class that's generic are called the sulfonylureas, an old class of medication. There's a bunch of different names of them. There is a potential for weight gain. This is the only oral medication that we use which can cause your blood sugar to go below normal. And patients who are older and who have or have kidney disease or kidney problems, the risk of low blood sugar goes up. So this has to be used with caution. This class, otherwise known as TZDs, has gotten a lot of press in the last few years. The 2 members of the category are Actos and Avandia. Avandia, both of the medications can cause fluid retention and weight gain. They can also, in patients who are at risk of heart failure, meaning they already have heart failure, which is a fluid overload situation, causing more fluid overload can be a problem. These patients who do not have heart failure do not have an increased risk. However, Avandia, specifically Avandia, has been linked with an increased risk of heart attack. Obviously, something we do not want in patients with diabetes. The interesting thing is that these 2 drugs are different. Actos has a beneficial effect on cholesterol in addition to blood sugar. Avandia has a worsening effect on cholesterol. So that may be part of the mechanism as to why Avandia has increased heart attacks. Avandia, because of all the concerns involved, the use of it has been significantly restricted to essentially it's just not used anymore. This new category, Incretin-based, this is what we talked about before. Your intestines can produce hormones, and these hormones help modulate the insulin that your body makes. So the 2 categories, these medications are oral. There's Onglyza, which is the newest one on the market, and Januvia is a little bit older. These are weight neutral, and they do not cause low blood sugar, and they're extremely well tolerated. Most people really don't have any side effects at all, very easy to use. The problem is they're not very effective at lowering A1C, so it's a trade-off. Exenatide or Byetta, and the newest one that's similar is Victoza. These are both by injection only, like insulin. These are associated with some weight loss by an average of about 5 or 10 pounds in many patients, and it's due to appetite suppression. The insulins that we use are much more flexible. Most of them come in pen devices that patients can dial up. Even patients who have some vision impairment can actually hear the clicks, so they can still use them. So insulin, we use insulin a lot earlier in the course of diabetes than we have ever before. Insulin has a lot of barriers, a lot of physician barrier, because physicians, they know it's more uncomfortable to start insulin, and starting that conversation with patients is a difficult discussion. And patients have a lot of concern about insulin. We all know people that have been put on insulin shortly before they've died. And people have a link that maybe that means my diabetes is worse, that it's severe, and that insulin is kind of a marker of that. But I really want to change that philosophy. If we use insulin earlier, it's possible that the reason why you've seen someone use insulin maybe towards the end of their life is because they should have used insulin earlier. More preventive. So if we institute insulin at an earlier stage in the disease, we can control the A1C earlier and prevent some of the longer-term complications. So in summary, we've seen there's been a dramatic rise in the number of people with diabetes over the past 20 to 30 years. This parallels the rise in obesity. Healthy lifestyle choices can delay or even prevent diabetes in those at risk. In patients who diabetes does develop, lifestyle change can help control their disease. It can help prevent or delay the need for medication, and those patients who are on medications can use less medications if they institute good lifestyle change. If diabetes is not well controlled by exercise and diet alone, there are many treatment options available. Certainly a team approach is the most effective way to control and get everyone at goal, and the most important team member is the patients with diabetes. Couple of semantics. I don't use the term, although I mentioned prevent, I would prefer the term delay. Delay the onset of diabetes is more realistic for many patients as opposed to preventing. because we may not be able to prevent. In someone who has a genetic predisposition, who has other risk factors, they may just get diabetes. But we can delay diabetes by 10, 15, 20, 30 years. Right? Patients who have diabetes can make lifestyle change to control their diabetes to the point where they don't need medication. Some people can actually control it to the point, if they start early enough, where their numbers appear normal. I would not say that that patient has gotten rid of their diabetes. I would say they are controlling their diabetes with lifestyle change. We know they already have diabetes because their blood sugar was already high, meaning it tells us a lot about that patient that they got to a higher blood sugar because of the weight gain that they had, that they lost, and then reversed that rise in blood sugar. But the underlying issues going on that could cause diabetes to come back are still there. Diabetes is a progressive disease. So we know that when patients are diagnosed with diabetes, many of those patients will ultimately require insulin. Now, I'm an optimist. However, I'm also a realist. We are diagnosing diabetes earlier and earlier. On average, it takes about 15 years for a patient who is diagnosed with diabetes to need insulin to control their diabetes. That's the progression of diabetes. They go from typically one medication, then two medications, then three medications, and then insulin. That's kind of the progression that you see. Right? And oftentimes insulin is delayed for a lot of reasons when maybe it should be started earlier. So 15 years is the average. Well, if we're diagnosing diabetes in 30s and 40s, it just goes to reason many of those patients will ultimately require insulin in their lifetime. So I want to set good expectations that while lifestyle intervention can reduce the amount of medications we need to use, it may not ultimately prevent the need for medication and maybe the progression to insulin requirement. So it shouldn't be thought that, wait a minute, I did all I had to do, I lost the weight, I'm healthier, I'm sleeping better, stress is controlled, and yet over the last 5 years my number continues to rise. I would tell someone in that situation, imagine if you didn't do what you did, you would probably have needed insulin earlier. You know what I'm saying? So there's benefits in different ways to kind of have expectations that are realistic. Yeah. Lifestyle intervention has never hurt anyone. So I'm never wrong to say to someone to do a lifestyle change. Because diabetes can affect the nerves going down to the feet, it's the nerves that are furthest from the brain that are affected first due to small blood vessel damage. So if you have a nerve problem where you cannot sense the toes and the feet, on top of that, your large blood vessels, which go to your feet, can get clogged. So you may not have as much blood flow to the legs. If you stub yourself and don't feel it, you can get a little cut that you don't feel, and you may not be able to bring the blood supply to fight infection, and that can cascade into something more serious. So I always try to look at everyone's feet when I see them as a reminder to them that feet are very important to look at and make sure there's nothing that is a risk factor of having infection, no open cuts, no in between the toes, make sure you dry them very well. If you have a sensation problem, you shouldn't be clipping your own nails because, again, if you clip and you don't feel that you clip too close, that can lead to infection. So all these, that's why we focus on feet. Most people, I don't want to raise concern too much. Most people with diabetes do not have these small blood vessel problems. Most people don't go blind. Most people don't have kidney problems. But they're at risk of it. And we can prevent it by good control of sugar. Yeah. And things like looking at your feet. The genetics is one factor. It is probably a big factor, but it is not the only factor. There is a term that's used, which I like. It's called the two-hit phenomena. Many conditions require, in my opinion, 2 hits for the condition to occur. 1 hit for diabetes is probably the genetic predisposition, something about your genes that predispose you in the setting of another factor which can cause diabetes. So for diabetes, if you have a predisposition and you have an environmental factor, such as obesity or using some medications can cause it, then you may get diabetes. But it's not to say that you have to have a family history of diabetes to know the genetics. Because if you said your parents, talking about you particularly, if you say your parents are healthy, maybe they were not exposed to the same environmental factors you were, so they never had their genetics unmasked, whereas you may have your genetics unmasked.
But say I live
Yeah.
an unhealthy lifestyle, would that actually change my genes to probably, my children would probably have a genetic predisposition, or does it not really change your genes that I already have?
Good question. Your genes themselves don't change. Your DNA is fixed at birth. What can change is which genes are turned on and which genes are turned off. It's a great question because a lot of research has shown, just like, for example, the trans fats, they probably turn on genes that should not be turned on. Or obesity may turn genes on that then make it more difficult to lose weight and may actually cause insulin resistance that even when you lose all the weight back to normal, you do not turn off those genes. So you have modulated your genetics, but ultimately it's the underlying genetic predisposition which you are affecting with your lifestyle.
I think that's what I was trying to ask.
Yeah.
So it's hard to turn them off when you turn them back on.
It can be hard to turn off, correct. Now, not to say that, and because you need 2 hits, if you have one really, really, really bad hit, let's say you have someone who is, for way of example, 500 pounds, but they have perfect genetics, no genetic predisposition. Their blood sugar may be 70, but they're very overweight. Whereas someone who has extremely bad genetics, their predisposition is very poor, and any environmental change is really going to be magnified. They may only be 5, 10 pounds overweight, but they may develop diabetes. So that's kind of the difference between the various factors that affect the risk. Absolutely. I think the importance of good, I would term restful sleep, should not be understated. Many people do not get restful sleep. They may get time in their bed, but it's not restful. Sleep apnea is a perfect example. Of course, that goes along with being overweight because of the apnea of the weight. But if you are not getting that restful sleep, it's kind of like taking care of your car. If you don't take good care of your car, right, it's probably not going to run as well as it should. And the problem with sleep is it affects your metabolism. It affects blood sugars just by themselves. In addition, when people don't sleep well, they're more tired, more likely to not do the things they know they should do because they're more tired. They don't exercise as much, they don't eat as healthy, and it's a whole cascade. They're more irritable, the people around them are more irritable, and it just cascades into more stress, which then affects their sleep, and it can be really, really tough for patients. So I have patients who have been well controlled, and they have a significant new stress in their life, which causes their sleep disturbance, and their diabetes gets very poorly controlled. And it's nothing that they've done differently except this external stress. So sleeping is very important. So 7% of all U.S. pregnancies are complicated by gestational diabetes, 1 out of 14. The old statistics are a woman who has had gestational diabetes, this is statistics, so it's an overall average, have a 50% chance of developing diabetes in their lifetime. But now, that may seem high, and it is. Well, people over the age of 60 have a 27% chance of diabetes. So it's doubling, but don't forget, 1 in 4 people over the age of 60 have diabetes. Isn't that staggering?
The fact that she had the gestational diabetes in both pregnancies, does that even put it up higher?
Yeah. It's hard to comment on an individual patient's risk because a person will either develop a problem or they will not develop a problem. It's not a percentage of, right? So once you have an individual, you can't really look at statistics. It may help guide kind of your thought process, but ultimately, again, the recommendation is going to be good lifestyle control. Yeah. Insulin resistance is where the insulin that you make does not work well enough to control the sugar. So as the insulin does not work well, your body responds by increasing the amount of insulin it makes. It figures, if 50 is not enough, let me produce 70. And it does that, and the sugars stay normal. Next year, it may have to produce 80. then 90, because insulin resistance continues to progress. And eventually, the pancreas cannot keep up with the demand of insulin. And the insulin that you make may be, right before you develop diabetes, may be 200. 4 times as much insulin as you would be producing if you didn't have diabetes. But maybe you have to produce 220. But you can only produce 200. You have a deficiency in the amount that you need, and your blood sugar will be high. Now, insulin resistance is associated with the higher blood pressure, the lower good cholesterol, the higher triglycerides, the weight, especially in the abdomen. These are all factors of insulin resistance. The term is metabolic syndrome in 2011. In patients who have prediabetes, they most likely have underlying insulin resistance. So you already have a defect in how your body responds to insulin. So if you're already at close to your capacity to make insulin, if you take prednisone or another medication which is known to produce insulin resistance, you may not be able to overcome the need for more insulin. Okay? So that's probably what you're seeing. And that, in my opinion, is what I would term you're unmasking what is underlying in your body. And you're doing it at an earlier state. So that if you have to take prednisone short term and you see sugars go up and you get off of prednisone and the sugars go back down, yes, the sugars came back down, but that should be a big eye-opener. That just shows what might happen in a few years if things don't change.